Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. Biosimilars are lower-cost alternatives to biologic drugs in pretty much the same way generic drugs are alternatives to branded drugs. It's taken concerted policy effort to get where we are today with generic drugs, where the vast majority of prescriptions are filled with generics, and their entry dramatically lowers the cost to consumers. But the regulatory regime for biologics is somewhat different from that for generic drugs, and the biosimilar market is newer than the generic drug market. All of this is even more complicated because in Medicare, some drugs are covered under the Part B benefit and others are covered under the Part D benefit. So how is the biologic market faring and what can be done to make it more robust? That's the topic of today's episode of A Health Podyssey. I'm here with Janice Jhang, a PhD candidate in health policy at Harvard University. Jhang, along with co-author Troy Brennan, published a paper in the November 2024 issue of Health Affairs that analyzes the biosimilar market and discusses potential changes in policy that could further promote adoption of biosimilars. We'll discuss this analysis in today's episode. Ms. Jhang, welcome to the program.
Thank you for having me. It's great to be here.
Well, I can't wait to ask you questions that I know are really hard to answer. This is a very complicated market, so I'm putting you on the spot here. But let's just start with how you could explain to us the evolution of the biosimilars market in the United States. I know early on people thought, wow, it's really not taking off. Seems like it's gotten a little stronger. What's your sense of how that market has evolved?
Yeah, definitely. I think we need to start with a bit of context as to how the biosimilars market really kicked off in the U.S. because, as you mentioned, the regulatory regimes governing small and large molecules are quite different. So just as a quick background, for small molecules, the 1984 Hatch-Waxman Act created a process for generic molecules to enter the market once the patent on a small molecule drug had expired, but this law didn't apply to biologics and their biosimilars. But over the past few decades, drug development has been increasingly driven by these complex biologics. And so under the Affordable Care Act, Congress enacted the Biologics Price Competition and Innovation Act, which was intended to complement the Hatch-Waxman pathway for generic molecules and create an analogous approval pathway for biosimilars. Now, because biologics are more complex than small molecule drugs, there are key differences in how the two regulatory regimes govern the entry and use of generics versus biosimilars. Too long to get into right now, but my co-author, Troy Brennan, did have an article in Health Affairs in 2015 comparing the legislative frameworks in greater detail. But essentially, factors like weaker statutory incentives, prescriber hesitation, and patent hurdles, which I will say are still very much ongoing, these factors resulted in fairly underwhelming entry and uptake of biosimilars in the first decade in this country. And that disappointment was generally reflected in the policy literature because generic medications have played such a key role in containing the growth of drug costs and increasing access and affordability for essential medications. We just haven't seen the same with biosimilars yet. However, in our paper, we point to recent government and industry reports as well as recent regulatory changes to say, actually, it seems like biosimilars are making substantial gains in the marketplace after overcoming patent hurdles. And we looked at the recent performance of the biosimilar market from three angles. And just as a quick summary, first, in terms of availability, there were initially concerns that statutory incentives for market entry were insufficient. And the first biosimilar application was filed nearly 2 years after the FDA issued its initial regulations. But now the U.S. has more than 60 approved products. Uptake has also increased in recent years. Recent launches have been gaining market share more quickly than earlier entrants. And surveys further suggest that provider receptiveness is also improving with growing experience and evidence to support efficacy, with some variation across provider specialties. And finally, prices are on the decline, through either biosimilars being priced lower than the reference biologics, the reference biologics reducing their prices to remain competitive, or both.
Okay, so that sounds like we always want instantaneous results, but markets take a while. And you mention a factor that's really critical here that's often left out of the market discussion, which is the receptivity of providers. I mean, these are prescribed drugs. And if prescribers don't think the similar or the generic is going to do as well as the branded or the biologic, they're just not going to prescribe. So you've got all of these factors. But I hear a relatively positive story, a slow start, but a growing market. And particularly, you ended on what I think is the most important, which is that in generics, what we have hoped for and experienced is that generic entry really reduces prices. And that, of course, is where we want this. Now, there's this very complicating factor here, and I'm going to stretch your. Well, I wouldn't say I'm stretching your capabilities. I'm sure you're up to it, but I'm going to ask you to explain something that I know is really complicated, which has to do with what is the behavior of the biologic manufacturer when the biosimilar enters with respect to discounts in formulary placement to try to preserve their market share and their market power. There's so many concepts in here you're probably going to have to introduce, but you mentioned it in the paper, and I can't miss this opportunity to ask you to explain it in a little more detail.
Yeah, it's definitely complicated. This paper could have been 10,000 words, 20,000 words.
But we wouldn't have published it if it was that long, right?
Exactly. This episode could be 3 hours easily. So I'll try my best to summarize and keep things as simple as possible. But yes, to your point, so a lot of the pricing dynamics that we've seen can be explained by the relationship between pharmacy benefit managers, or PBMs, and pharmaceutical manufacturers. And so just as a quick overview, PBMs negotiate on behalf of employers, insurers, and Medicare Part D plans, and they compete on the basis of their ability to reduce costs for these clients. And that can be achieved through either price decreases or discounts, most often delivered through rebates. In our experience, most PBMs and clients have preferred rebates, and these rebate contracts involve PBMs guaranteeing their clients a certain rebate amount over a given period of time. So now, when a biosimilar competitor enters the market, to your point, the reference biologic manufacturer wants to retain their market share. So what they do is they often offer steeper rebates to the PBM and negotiate more favorable exclusive formulary placement. From the PBM's perspective, they need to meet their rebate guarantees with clients. And so a large discount on a biologic with a high list price and large volume can be quite attractive. One implication of this, though, is that even when biosimilars enter the market at a lower price point than the reference biologic, they may not receive favorable placement on formularies and consequently struggle to capture volume. And patients can be left with the short end of the stick because patients paying a deductible or coinsurance for their drug benefit will often face the list price of the drug and not the discounted negotiated price.
So again, we could dive so deep in here we would never get out. But without getting so deep into the rebate system, which we could lose the whole day talking about. What you're describing, I think, is a situation where, because of the ability to use rebates as a tool, reference biologic manufacturers have this mechanism available to them of offering higher rebates, and that holds their market position.
Yes.
Through better formulary placement. Obviously, they give up some money because they have to pay the rebates, but they retain a high list price. And so if we're looking at sort of the pricing environment, we're not seeing the list prices fall as fast, but we are experiencing increases in rebates, some of which will be captured by patients, but some of which will not. It'll be kept either by the PBM or be lost through these cost-sharing provisions that you described.
Yep.
So your paper references the Humira story as one of misaligned incentives. This seems to be sort of an example of what you described earlier, which is that the launch is slow, but over time, things get better. So can you say a little bit about what played out there and what lessons you draw from it?
Yeah, definitely. I think the Humira story is actually a perfect follow-up to your previous question. And I think the Humira story is super interesting and one that is still very much evolving. I mean, even as we were writing the paper, we had to update our writing as news continued to come out. So for context, Humira is the world's top grossing biologic indicated for multiple autoimmune conditions. And to understand its scale, a fun fact that I heard and love is that in 2021, revenues for Humira were close to McDonald's globally, which is just wow, right?
Right.
So I think the slow start for Humira's biosimilars was disappointing, but perhaps unsurprising for folks who are really familiar with the space. So first, the biosimilar manufacturers had to overcome these patent hurdles imposed by Humira's manufacturer AbbVie, and eventually the companies settled on delaying biosimilar entry into the US until 2023. But once the biosimilars became available, they ran into obstacles getting covered on formularies, especially getting preferred coverage over the branded Humira. So in that first year, in 2023, branded Humira remained on the major commercial and Part D formularies. And by the end of the year, biosimilars captured less than 2% of Humira's volume. And for context, it might be helpful to compare this to an analogous case in the small molecule market. Before Humira, there was Lipitor, blockbuster drug for cholesterol. And at least up until a few years ago, the last time I checked, Lipitor was the number one selling drug over the past few decades, even above Humira. So you can imagine its scale. But once Lipitor's patent expired in 2011, its revenues fell 80% in the first year, and its price has declined something like 95%. That just isn't what we've seen with biologics so far, especially Humira. But we do think the tide is turning for a number of reasons that we discuss in the paper. And just to touch on one, and kind of tying back to the previous question, we know Humira has been able to retain most of its volume, but in that first year of biosimilar competition, its net price fell 38%, indicating that AbbVie did have to rebate much more steeply to retain that market share. From the PBM angle, CVS Caremark announced in April of this past year, in 2024, that Humira would be replaced with biosimilars on its major commercial formularies. And within the first 2 months of doing so, it saw over 80% of its Humira volume shift toward the biosimilars. So I think PBM's now displaying increasing willingness to give biosimilars preferable placement on formularies, and clear signs that that does effectively move volume to biosimilars is a promising sign for other biologics and biosimilars that don't have as large of a market as Humira. But kind of beyond this paper and thinking ahead, there is one open-ended question, or multiple questions probably, that I've been thinking about. And this is where things start to get pretty wonky if they haven't already. But along with the formulary changes that have been happening with Humira, these major PBMs are also launching subsidiaries to partner with manufacturers to co-manufacture the Humira biosimilars. And there's been a lot of discussion around the vertical integration that we've seen across PBM, payer, provider, and pharmacy. And now it's starting to expand to the manufacturer level as well. And so the effects of that on cost savings, biosimilar competition, especially for manufacturers that aren't partnered with the major PBMs, that remains to be seen. So definitely a lot going on in this space and a lot of directions for future research.
Well, I'll invite you back to talk about vertical integration within pharmaceutical manufacturing. I don't know that we'll cover that today, but I'm glad you teed that up. So keeping our focus a little closer to the biologics pricing, I want to ask you some questions about the policy context. We are, of course, a policy journal. We'll discuss some of the policy options after we take a short break. And we're back. I'm speaking with Janice Jhang about the market for biosimilars. We've covered a lot of ground about sort of how the biosimilar entry does and does not occur, and hopes for speeding it up given the high rates of discount we see on the generic small molecule side. We'd like to see some of those benefits come a little faster on the biosimilar side. We've discussed some of the context of market entry, but there's this interplay with Medicare that I want to focus on a little bit more closely. Again, hard to do this quickly or simply, but drug payment rates are different in Part D than in Part B. And biologics are primarily in Part B, but not entirely. So could you say something about an argument you make in the paper about the potential of using volume-weighted average pricing for biologics and biosimilars within Part B? What does that mean? How would it work? And why do you think it's worth exploring?
Yeah, so currently in Part B, payment for biologics and biosimilars is separate, and the entry of a biosimilar doesn't have a direct effect on the payment rate for the reference biologic. And so right now, the way payment is working, per temporary changes effectuated by the Inflation Reduction Act, is that the biologic is reimbursed at an amount equal to its average sales price, or ASP for short, plus a 6% markup. So, for example, a drug with an ASP of $100 will be reimbursed at $106. Its biosimilar will be reimbursed at its own individual ASP, plus a markup of 8% of the reference biologic's ASP. So if the biosimilar has an ASP of $80, it'll be reimbursed at $80 plus $8, which is 8% of the reference biologic's ASP. Very confusing, I know. And just a caveat too, this is an extremely simplified example. The percent markup is in reality effectively lower because it's been adjusted per sequestration under the 2011 Budget Control Act. But for the purposes of this illustration, we'll keep it simple.
You also used really low numbers.
Yes. Oh, yes.
These are not $100 drugs, by
Yes. Let's magnify it by 10,000 minimum. So back to the example, the provider is now getting an $8 markup if they prescribe the biosimilar and a $6 markup if they prescribe the biologic. So the IRA has essentially tipped the provider's payment incentive toward the biosimilar for the first time. And we don't yet know what the impact of this policy change has been or will be on biosimilar prescribing, but a great direction for future research. Ultimately, though, it doesn't address the underlying financial incentive for providers to choose the more expensive drug. Because a percentage markup based on ASP will always result in higher reimbursement for drugs with higher ASPs, the provider's incentive is still to choose the more expensive drug. Now, this is different from the reimbursement scheme for small molecules in Part B, and this is where we think the two reimbursement structures could be better aligned. For small molecules, reimbursement is based on a volume-weighted ASP of the brand and its generics. So once generics become available, providers stand to gain more by choosing versions of the drug that have a cost lower than the ASP-based reimbursement rate. In other words, they can maximize the spread between the reimbursement amount and the drug cost by choosing the cheaper drug. This allows the brand and its generics to compete on price, and so the volume-weighted ASP for the molecule declines over time. Modifying biologic and biosimilar payment to be based on a shared payment rate, like small molecules, is not a new idea at all. I mean, MedPAC has been discussing this since at least 2017. But there has been previous concern expressed that this policy could lead to inadequate reimbursement and weaken incentives for manufacturers to develop biosimilars. But I think there are ways to accommodate some of those concerns to a degree. For example, some have proposed that a shared payment rate could be phased in incrementally instead of immediately. Another option would be to just implement a shared rate after a set period of time to account for the time it's been taking biosimilars to capture volume. And so Part B payment is just one policy lever that could be wielded more effectively to reap the benefits of biosimilar competition.
Well, that's sort of where you ended is exactly what I think about as you describe all of this, which is that these policies all create incentives. And if we're trying to shift volume over toward the biosimilar, we have to identify, as you have, as others have, this place where the incentives are impeding that transition and undo them. But of course, there are interests on the other side that don't want to see that happen. Let's cover two more policy ideas before we wrap up. You mentioned in the paper interchangeability as a designation and how it guides prescribing behavior. We discussed a little earlier the role of the clinician in this whole ecosystem. Can you say a little bit more about what the interchangeability designation is? Definitely.
So in the US, there are two designations for biosimilars, interchangeable and non-interchangeable. And now this is different than for generic molecules. In the US, generics are all considered to be interchangeable with their reference products. To receive the interchangeability designation, manufacturers essentially have to demonstrate that switching between the reference biologic and the biosimilar produces the same clinical effect and no additional risk. So there are typically additional clinical trials involved. And whereas the first non-interchangeable biosimilar received FDA approval in 2015, it wasn't until 2021 that the first interchangeable biosimilar received approval. And to be clear, interchangeability in the US is a legal distinction rather than a clinical one, but it does appear to matter to prescribers. For example, over 60% of physicians have reported being comfortable prescribing a biosimilar for Humira only if it is considered interchangeable. And over 70% of patients report that they'd be very likely to start to take a biosimilar over a biologic if their physician recommends it. As evidence is growing to support the safety and efficacy of biosimilars, the FDA does appear to be growing more comfortable granting these designations even without switching studies. In fact, by June of this year, the FDA had approved 9 out of the 13 interchangeable biosimilars without switching data, and they issued draft guidance that would generally allow interchangeability status to be granted without switching studies. Going one step further, the Biden administration and HHS have proposed eliminating the statutory distinction altogether so that all biosimilars would be deemed interchangeable with their reference biologics. It's also important to note that in most states, the interchangeability designation is required for pharmacies to be able to substitute a patient's biologic medication for a biosimilar. And so this issue of interchangeability is inextricably tied to state-level pharmacy substitution laws. We don't yet know the exact impact of interchangeability and state-level substitution laws on the uptake of biosimilars, although researchers are currently working on that question. But evidence from the small molecule market suggests that this fragmentation across states could impede generic uptake, potential savings, and ultimately improvements to treatment adherence and patient outcomes.
Well, so that's another dimension of the dynamic. And then just to add yet another thorny topic, you also mentioned in the paper copay coupons, which have been much analyzed. They also affect this market. Can you say a little bit about the role they play in biosimilar adoption and maybe some changes you think are worth considering about?
Yes, definitely. A lot of thorny topics today. So manufacturers often have these copay coupons that commercial patients can use toward their deductible or copay for their drug. So for example, in 2022, before biosimilar competition, patients paid less than $10 for 82% of commercial Humira prescriptions because of AbbVie's coupon. So when there aren't any lower cost alternatives available, these coupons can significantly lower patients' out-of-pocket costs. But when there are lower cost alternatives available, there can be some negative consequences. Commercial plans often require higher copays for branded medications when generics are available to try to steer patients toward these cheaper options. But when a coupon is available for the branded medication, a generic option may not actually offer substantial cost savings to the patient, who then may not feel sufficient incentive to switch to the generic. And research has suggested that these coupons could increase the sales of branded medications by more than 60% by reducing sales of generics, and could increase retail spending by nearly 5% in the 5 years after generic entry. So you can see how even if commercial payers give biosimilars favorable formulary placement, the reference biologic manufacturers could leverage these coupons to circumvent the impact of less favorable formulary placement and higher out-of-pocket cost exposure for patients, which could then result in lost potential cost savings that could have been passed through to patients via premiums or add unnecessary administrative burden to the system. So in the absence of regulation, PBMs have designed programs to counter the effects of copay coupons, like copay accumulator and maximizer programs, which are a whole other topic that we could spend hours discussing. But these programs also have flaws that could result in additional harms to patients. So some states have now taken actions to counter these programs that are countering coupons. Just super wonky. Now, on the other hand, some states have taken action on copay coupons. In particular, California and Massachusetts have prohibited coupons for branded medications that have generics available. But in terms of how successful these bans have been in increasing generic substitution, the evidence thus far is limited and mixed. But we do think it's a natural extension to consider this type of reform for biologics with available biosimilars, just as you mentioned, another policy lever for facilitating biosimilar adoption, promoting a robust biosimilar market, and producing cost savings, especially because many biologics are very expensive and there's large potential for cost savings that could be achieved.
Well, Ms. Jhang, you've done an incredible job covering a lot of complex topics in drug pricing and biosimilars. This wasn't a university exam, but if it were, you more than passed. But it really, in all seriousness, this is such a complicated topic. I really appreciate the insights that your paper brings that you were able to explain today around a market that we really need to succeed in order to keep costs within bounds, that has some very significant distortions both on the public payer side, we talked about Medicare, as well as the commercial side, you just talked about drug coupons, and the regulatory structure as a whole. And so continued attention to the evolution of the market, drawing lessons from the actual biologics and biosimilars and seeing how they spread, something we've published about numerous times in our journal, will hopefully lead us to better policy. And it's analysis like yours that weaves the evidence together that helps point us in the direction of where we might want to go. So I really appreciate you having written the paper and explaining so many of the concepts. Thank you so much for being my guest today on Health Podyssey.
Thank you for having me.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about the Health Podyssey.